If you've ever been told your heavy periods are just one of those things, or that painful cramps are normal, you're not alone. Many women live for years with symptoms that disrupt work, relationships, confidence, and day-to-day life, only to be reassured, dismissed, or repeatedly treated without a clear explanation. One possible cause is adenomyosis. It's common, under-recognized, and often misunderstood. And because its symptoms can overlap with fibroids, endometriosis, and general heavy periods, it can be missed or labeled incorrectly, meaning women may spend years managing symptoms without a proper plan. In this video, we're going to break down adenomyosis in plain language: what it is, what it can feel like, how it's diagnosed in the UK, the treatment options available, and the questions you can ask to get clearer care. This is not about self-diagnosing. It's about giving you a map so you can walk into your GP appointment prepared and so you can understand what your options are. Adenomyosis happens when tissue similar to the lining of the womb, endometrium, is found within the muscle wall of the womb, the myometrium. That can make the womb muscle thicker, more tender, and more prone to inflammation and heavy bleeding. Think of it like this: the womb lining is meant to build up and shed during your cycle. In adenomyosis, some of that lining-like tissue is living in places it isn't meant to be. As your hormones change across the month, that tissue can also respond, contributing to pain, bleeding, and a boggy or enlarged uterus. Adenomyosis is not the same as endometriosis, although some people have both. Endometriosis is typically tissue outside the womb. Adenomyosis is tissue within the womb muscle. Adenomyosis can look different from person to person. Some women have mild symptoms, others are severely affected. But the most common patterns include heavy menstrual bleeding, soaking through pads or tampons, needing double protection, flooding, clots, painful periods that may worsen over time, pelvic pain that can exist outside your period too, pain during sex, not everyone, but it can occur, bloating or pelvic pressure, sometimes described as feeling pregnant or swollen, fatigue, especially if heavy bleeding leads to iron deficiency anemia, a uterus that feels enlarged, sometimes noticed on exam or scan. One important emotional truth: heavy bleeding and pain are often minimized because they're common, but common doesn't mean acceptable. If your period is affecting your quality of life, that matters medically. Adenomyosis can be overlooked for a few reasons. Symptoms overlap with fibroids, endometriosis, perimenopause changes, thyroid issues, and general heavy bleeding causes. For years, adenomyosis was more likely to be confirmed after hysterectomy, when the womb was examined under a microscope. That history has left a lingering myth that it's hard to diagnose. Some women are offered treatment pathways, like painkillers or hormonal contraception, without clear investigation, especially if they're young or have been told it's just periods. The result can be years of trial and error, not because clinicians don't care, but because women's pain is too often treated as background noise. We don't always know exactly why adenomyosis develops. The honest answer is that medicine is still learning, but what matters for you is this: adenomyosis is not your fault. It's not caused by being weak, not caused by stress, and not caused by something you did wrong. It may be associated with hormonal factors and uterine changes over time. It's also more commonly identified in certain age groups, particularly in women in their 30s and 40s, but it can occur earlier too. Many women hear adenomyosis and immediately panic about fertility. Let's slow down and be precise. Some women with adenomyosis conceive naturally and have healthy pregnancies. Some women experience difficulties conceiving or may face higher risks of certain pregnancy complications. Adenomyosis can coexist with other issues, like fibroids or endometriosis, which can also affect fertility. If you're trying to conceive, the goal is not to label you as infertile. The goal is to get a realistic assessment and a plan. If symptoms are severe or if you've been trying for a while, it's reasonable to discuss fertility earlier rather than later. especially if time matters for your body. Diagnosis often starts with your story. Your symptoms matter. A good clinician will ask, how heavy is your bleeding? How long do your periods last? Do you have clots or flooding? Is pain limiting your daily activities? Do you have pain during sex? Are you trying to conceive? Do you have symptoms of anemia, fatigue, dizziness, breathlessness? Then, the next step is typically imaging, most commonly a pelvic ultrasound, often transvaginal for clearer detail, if you're comfortable with that. In some cases, MRI may be used to clarify findings, especially if ultrasound isn't definitive. You may also be offered blood tests, particularly if heavy bleeding suggests anemia, and to rule out other causes. A key point, you deserve clear communication. If a scan is normal, but your symptoms are not, it's reasonable to ask what else could explain them and what the next step is. Treatment depends on your symptom severity, your age and stage of life, whether you want to conceive now, later, or not at all, and your overall health. The aim is usually one or more of the following: reduce bleeding, reduce pain, improve quality of life, protect iron levels and energy, and align treatment with fertility goals. Many women start with treatments that help symptoms. Pain relief, anti-inflammatory painkillers are often used for period pain. Ask your clinician what is safe for you. Treating anemia, iron tablets, or other support if needed. Hormonal treatments to reduce bleeding and pain. One of the commonly recommended options for heavy bleeding in the UK is the levonorgestrel-releasing intrauterine system, often known by brand names such as Mirena, which can reduce bleeding significantly for many women. It may also help pain for some. Other hormonal options may include combined hormonal contraception or progestogen-based methods, depending on your medical history and what's appropriate. You don't need to earn these options by suffering first. If your symptoms are impacting your life, it's reasonable to ask for active treatment. If medication doesn't control symptoms, or if your quality of life is significantly affected, you may be referred to Gynaecology to discuss procedural options. Depending on your situation, options can include endometrial ablation, not suitable for everyone and generally not advised if you want future pregnancy. Uterine artery embolization, more commonly discussed for fibroids, suitability depends on the diagnosis and individual factors. Hysterectomy, removal of the womb, as a definitive treatment for adenomyosis for women who do not want future pregnancies. This part can be emotionally loaded. Some women feel relief at the idea of a definitive solution, others feel grief even when they're certain they don't want more children. Both reactions are valid. What you deserve is a discussion that respects your body, your future, and your values, without pressure, shame, or minimization. Adenomyosis doesn't just affect your uterus. It can affect your work, parenting, relationships, and identity. Practical supports that often help include tracking bleeding and pain for a few cycles. It can strengthen your case for escalation. Asking about anemia testing if you're exhausted or lightheaded. Planning pain relief proactively, not waiting until pain peaks. Heat, gentle movement, rest, and support when symptoms flare. Communicating needs at work and home without apologizing for being ill. Lifestyle changes won't cure adenomyosis, but they can support coping, sleep, nutrition that supports iron, and stress reduction that protects your nervous system. The goal isn't perfection, it's reducing the load your body is carrying. If you suspect adenomyosis, or you have heavy bleeding and pain without answers, consider asking, can we assess heavy menstrual bleeding and severe period pain properly, not just treat it repeatedly? Can I have a pelvic ultrasound to look for causes like fibroids or adenomyosis? If the ultrasound isn't clear, would MRI be appropriate? Can we check for anemia and iron deficiency? What are my treatment options if I want to preserve fertility? What are my options if I do not want future pregnancy and I want long-term symptom control? What is the timeline for referral to gynaecology if first-line treatment doesn't work? What should I do if I'm soaking through pads, passing large clots, or feeling faint? You are not being dramatic for asking. You're being responsible. Adenomyosis is real. Heavy bleeding and pain are not personality traits. They are medical symptoms that deserve investigation and treatment. If you've been carrying this quietly, I want you to hear this clearly. You don't have to normalize suffering. You deserve clarity, options, and a plan that respects your life. Adenomyosis and endometriosis can look similar, they can overlap, and they're often confused, especially when symptoms include heavy bleeding, pelvic pain, or pain during sex. So if you want a clear breakdown of endometriosis, including the signs people miss and what to ask your GP, tap the thumbnail on your screen now. It'll take you straight to our endometriosis video.